All right. Thank you very much for this, for the invitation. I, even though this is about digital twins, to a certain extent, I got brought into that domain by a colleague in Aarhus University, Peter Gorm Larsen. My background is mostly in formal methods in formal verification, applied to avionics and then now to medical devices. So this talk is about applying digital twins to a new organ preservation technology, which became a spin-out company from Newcastle and NHS, where I am a co-founder from the beginning. And right, so what's the problem that we're trying to solve here? Organ demand outpaces supply pretty much, very sharply. And the trouble is you are having acceptable criteria stretched, namely, what's a good organ that you would like to allow for, particularly when you take into consideration there are 2 or 3 types of death. If you never heard that, so you have circulatory death, brain death, and extended criteria death. The graph there is to do with, that's where an organ is available, and that's what an organ got transplanted. So for some organs, like the pancreas in particular, it's quite low transplantation rate. For other organs like lungs, you get the highest waiting list mortality, but also the highest wastage, which is a kind of contradiction in terms, right? So what you're trying to do is get that area of the curve or that area of the curve and push it upwards, right? And to do that, you need a kind of some technique to preserve the organ for longer. And that means devices, okay? In terms of organ preservation technologies, and I'm going to spend some time explaining how organ preservation works, I guess, because otherwise it's a bit it's actually quite simple, the models, which is a good thing. So that means we can do a lot in that area. So you have 2 types. One is passive, which is just a code box, which is current standard of care, if you like, cheap, easy, but relatively logistically easy, cheap to maintain, but it has its problems in terms of how long can you use it for and the quality of the preservation time. And then you have active techniques where very fancy machines from this is life port for kidney, all the way to the very complicated organox machine for liver. And they can be cold preservation, whereby you put the metabolism down as much as possible and keep the organ happy, breathing, as it were, without metabolic processing. Or you can have, the organ believes it's in a body. But that one is like a BMW, to use the previous speaker, a BMW per use. It's very expensive, 50,000 pounds, and it's the size of this, more or less the size of this table. If you have 5, 6 organs in a theater, you can't have 5 or 6 of those there. And then we have our device, which uses a different technique called persufflation. Perfusion, by the way, it's the passing of some liquid through the vasculature of the organ. Persufflation is a kind of perfusion. So, what's persufflation? Well, it's basically humidified oxygen gas perfusion. So instead of passing liquid through the organ, we pass gas. It has a number of advantages in terms of resistance, prevention, and the gas will find the least way to go through, and it will go even to the capillaries, whereas liquid might damage the capillaries. So there are some medical advantages to this. And another thing about our device is that it's multi-organ. One of the problems with the other devices is you have one for kidney, one for heart, one for liver, and in our case, it's one for all 5. Okay. Of course, I'm not a medical person. This is all in collaboration with my colleague Bill Scott, who is the guy who understands this and came up with some of these ideas in the first place. So what we're doing is, to a certain extent, building a box. So to give a concrete example, for pancreas, there is no machine in the world for pancreas preservation, right? Pancreas goes on an ice box. Pancreas is one of the most complicated organs because it digests itself as soon as you die. Therefore, the clock ticks very quickly. What Bill's research did back in Arizona when he was there in the US was that with persufflation, you get 4 times the time, you get almost 2 times the yield, and almost 4 times the function. What does that matter? Well, this changes the geography of where you can take your organ to. It changes the logistics. You don't need to do it overnight or on a Sunday evening. And it changes the transplant pool, if you like. More importantly, the yield is how many, pancreas transplant, you get the You get the organ, you digest it, you isolate the cells that produce insulin, and then you give that to the patient. So it's a bit different than a heart or kidney transplant. So what you're looking for in a pancreas transplant is high functioning yield. So high yield here means more islet cells alive after the transplantation, after the preservation period. And function here is happy islets produce more insulin. That's what you want. In cold storage cold storage boxes, you need something like 3 to 4 pancreas for one successful insulin-independent transplant. Right? Each one of them costs 40,000 pounds or so to do, so it's an expensive thing. Whereas if you have one of those, you can do it in one shot, for example, to insulin independence. Okay? So it matters the kind of preservation technique you use. That's the point, I guess. So the scuba box in that case, it's a control system. We call it DOC, and basically it's a control loop that makes sure that flow is maintained over time through pressure modulation. It's valid for all those organs there: pancreas, liver, kidney, heart, and composite tissue. So that's for hand and face transplants. And it has some now active temperature monitoring as well with a Peltier. So this was used in the context of a digital twin work with Aarhus. So we built something like 30 of those and shipped it to various places, some around the NHS in the UK, some in the Netherlands in Leiden, and some in the US in Arizona, but also in Ohio, and now in the so-called TMC, Texas Medical Center in Houston. And yeah, Voyage, which is the prototype version for going on retrieval. Sorry, this one was on the lab only, but this one goes on retrieval. This is still a research-based organ preservation machine, but there is another version called Flight that would go on retrieval on the back of an ambulance or on a plane. And as I said, it does all 4 organs. And it does that by having changing of these different kind of enclosures. Just to make a point, the first successful trial of this was back in 2022, where Bill is there with Derek Menace, the head of NHS-BT, the Blood and Transplant Service for the NHS. The box then, in a nutshell, I'm sorry if I'm going a bit fast, it is hypothermic, so it keeps the organ cold. It's oxygenated. It's humidified. That's more for the medical side. The fact that it's modular matters for its logistics capability, its cost. It's auto-portable, which means you can stack 5 or 6 of them and put in a theater, and it's much easier to deal with. It fits precisely the NHS, or well, medical environment, if you like, a bench that you would have on hospitals. So there is this kind of a forethought, if you like, and this is all Bill's experience in doing this for many years, in understanding what are the pain points from the lab technician through to the surgeons, through to the OPOs, the organ procurement organizations, what matters for each one of those actors in the process. In terms of the software, there is a system that provides intelligent feedback in terms of how was the journey, right? You have a 24, 72-hour preservation time, and the journey then will have many bumps along the road, for example. Are those bumps relevant? A surgeon on the other end wants to say, is it to go or no go? Or rather, it's not making a decision for you. It's offering you, here were the points where you should pay attention to on the 72-hour time series. This was modeled using formal reasoning tools like VDM, and proved certain properties with the Isabel theorem prover. The proprietary aspect of this is each organ type has a container. The container, one of the things in medical devices that has a lot of problems is user interface errors. So you are at 3 in the morning trying to type something when you are tired or overstretched. What you want is something that's straightforward. My work in payments before, I said, okay, the container is like a card and the box is like a terminal. The card comes to the terminal and they talk. If they have the right keys and the right instructions, there are no buttons, no faffing around. Okay? So the machine is extraordinarily simple to use for that reason, but then at the same time secure to use by design. Same technologies used by wave and pay protocols. And no medical device has that kind of thing yet. And yeah, the control system itself was also developed using verification in mind, where we are MISRA compliant and we've done some code level C verification on the device drivers. And at the moment for the industrialization time, we are partnering up with a company called D-Risk that does autonomous systems development, and it's their first medical device. We've got a few patents on this. Digital twin side. I hope that's clear. I'm sorry it was a bit fast about what is it we're trying to achieve. We're trying to get organ preserved for longer that provides higher function, and with that it will achieve various changes in logistical capability, in cost reduction. The use of an organox machine is, as I said, 50,000 pounds. The use of ours is something like 500 to 1,000 pounds, depending on the market. That's the UK. In the US, might be $10,000 instead of $100,000 or something like that. Right? So what we want to do, Peter Gonlas is suggesting, okay, let's digital twin this. I said, okay, fine. How digital twins work? In my understanding of it, you can use so-called twins and shadows, whereby a shadow is just the half side of a twin, if you like, in the sense that all that a shadow does is monitor. So you can have visualizations that show you what's going on, the time series of how the pressure is varying over time. You have safety monitoring if certain design features were going off the mark. You have predictive maintenance, like Mag had said earlier. You can use the twins to know when things need to go back to base rather than fail in service. You can do support for decision making, which is what I was saying about telling the surgeons at the point of transplant what happened to the organ that they should pay attention to. And that's all passive, whereas the twinning bit comes when you actually could interfere with the machine's control. And that happens in twins for reconfigurations, robustness, and optimizations. But the trouble here is if you do that, you are into a regulatory nightmare, right? Medical device regulatory processes can be on the millions of pounds to do a trial. And if you're having that in there, your software goes to class 3 and then game over cost-wise. Whereas if you are on this world, your software can be self-certified. But we are taking another thing Maya had said about taking advantage of the certification weakness or loopholes. To a certain extent, the certification authorities know about this, and they are very worried because apps are coming, digital twins are coming. They know that. They want them to come, but they don't have a certification environment to deal with it. And they kind of go like, pass. You can pass for the first 10, but not for the first 1,000. and yeah, so we're actually having a meeting in January to discuss those things. Right. So what's the twin like? You have the control software and the controller to the various sensors. You have flow, pressure, temperature, battery, and so on. They're relatively straightforward in the hardware. The data goes to the so-called smart audits that does the intelligent feedback of what happened with all that data. And we want to have traceability of what's happened. We want to have the opportunity to reconfigure things. Again, this was a paper where we suggested what kind of twins should we do. In the paper, we suggest things like a model for oxygen flow and pressure regulation under preservation of each one of these organs. Obviously, if we could twin the organ itself would be great, but that's harder. Here, twinning the organ doesn't need to be the entire physiology of the organ, but just say, for example, a pancreas has to produce that much insulin per hour, a kidney has to produce that much Wee per blood volume, and so on. Okay, so you can simplify your model, if you like, model only what you need. But then the passive models is to do with all, temperature, humidity, battery consumption, and so on. The visualizations have to do with trying to do predictive maintenance, or when will what would you call it? When your problem is going to come, and as a consequence, take preventive measure or alert the user. The smart feedback I've mentioned takes into account also the context under which the alert's taking place, because if you are in the theater and you have a blockage or a leak, you can do something about it. Once the box is closed and you're on an ambulance and you hit the bump on the road or turbulence on a plane, there's no point warning you, right? Because you can't open to fix it. So, but you want to log it and tell to the surgeon when you get there. So there is a kind of a modulated notion of what gets told when, to whom. we've then actually done one of those already with Aarhus. It was a master's project last year. These are shaded for commercial reasons, I guess, but the point is we were doing, there was a simulated curve for pressure, and we knew how the pressure would look like based on what was measured to achieve the flow that you wanted. And you could use, I'm going beyond my knowledge here, but our colleagues that who uses a technique called Kalman filters, which is I think it's a learning tool that would predict what would this look like in more general terms. And this is as far as my knowledge of this goes. But I guess the point of this is to say we have N of 1 for digital twins in practice, in reality, where it was useful to scuba to know how certain flow modulations should take place, particularly for predictive maintenance. Okay. They had a problem because we use a gas canister, a hospital-grade gas canisters. In Aarhus, they had to use a compressor because getting a gas canister in a computer science lab is not an easy thing, apparently, explosions and all that. But the compressor has a kind of dun, 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 dun. So that changed how this pressure looked like. So we had a kind of a noise in the curve, if you like, there. I guess the point I'm trying to make is a project that has computer science in a medical domain is very different because, how do you get a pancreas? How can you actually get one? It's a hard, very complicated, regulatory speaking thing to get. So the point is we could still do more twinning in the lab. We have Bill's lab has licenses for all organs. Newcastle is one of the only centers in the UK with that, which is a nice thing. Another one was we were trying to deliberately inject faults to see if it was predictable. And these are two concrete examples of that where here, this is resistance, that's pressure, that's flow. So if the flow is kept constant, but you had a drop in pressure with some resistance, it's probably a leak somewhere. Similarly, if you have a block, you'd have a high pressure, drop in flow, and high resistance. So you can start to, by how these curves vary, get additional information on how to either detect or even attempt to predict whether this is about to happen or how often it happened, or an introspection of that kind of curve into a decision support software to tell the surgeon afterwards. So, am I for time? Okay, sorry if I went too fast there, but so within the Scuba device, what we're trying to do is to have using digital twins to emulate scenarios. Because imagine, we started doing this actually with just a column of water, gas going through a column of water. That's all that there is in an organism so far as this pressure experiment was concerned. You want to play with your system as much as possible and have a model that simulates it well enough, because you're not going to want to waste 10 pancreas all that, right? So it's crucial to get twins here in the right shape, so that you have to, adequate calibration, adequate, what do you call it? What kind of choices should you make for things like, for example, a pancreas is a very soft tissue, a liver is much harder and denser and bigger tissue, and the kinds of models for each will be very different for that reason, but you would like one for each. We have at the moment, as I said, one for temperature in general and the oxygen flow and pressure for the pancreas, but we want to have twins for each one of the organs. So there is opportunity to do more work there. We haven't explored much the maintenance scenarios prediction yet, but we do want this as well, very much so. And obviously, the decision support software is to give you optimal, what would you call it, feedback on whether a overpressure for a particular amount of time. So it takes into account two dimensions. It's not just a time series. You like to know, for example, if you are overpressuring, say very high overpressure for a few seconds, how is that compared with is light overpressure for a few hours, right? So there are some calculations needed there to determine what kind of scenario have you passed through your 72 hours that you'd like to give feedback on. Okay. Now, this has been part of a work of a PhD student of ours that it uses, again, the smart audits technology, which effectively gives you this kind of real-time systems emergent behavior audit trail and audit control. And this is also mathematically bound, which means the answers you get have it's not clever in the sense, it's clever in the sense of an intelligence, but it's not artificial because we can explain it, right? And it's deductive, right? We can tell exactly why I got there. So it is used for now for gas leak management, for pressure and flow control, but we envisage a number of other applications to this. The trouble with the challenges we've got are things like the accuracy of models, because, for example, the control software regulates pressure for the exit of the dock box, but the tubing to the organ and where the surgeon puts it into the organ will have a delta there of pressure that you'd like from the target pressure to so the PID controls for, say, 100, okay, the pressure that gets to the organ is what, 90, 80, 102? Well, it can't be more, sorry, but the point is, what happens if it sloshes around as well as you're moving things, right? So how do you account for that? So in other words, it's not just PID control. And accuracy of models would require some kind of organ under preservation models, and that's another level of digital twinning capability. We would like to use real-world data. So this machine, one of the things that's very good about Scuba's being inside different centers is that for pancreas in particular, because there is nothing else around, anything we can give them, they take it, which means we have real-world trial data for free, or at cost for the box, if you like, and that means we have real-world data for calibrating our work. For example, in the US, there are centers where they would be happy to give us 100 organs they would throw away instead. And somebody would take those organs and prepare them, spend the money preparing them, because they have plenty of patients that need it. Type 1 diabetes is a pretty serious issue, a pretty serious condition. But then you get the challenge of regulatory pathways, because funnily enough, for pancreas, this is not a medical device. For a heart, it is a medical device. For a liver, it's a medical device. For a heart, it's a safety critical medical device, and this has to do with the nature of transplant. As I said, pancreas transplant goes from the donor to the lab to the recipient. So whereas a heart transplant goes from donor to donor, where when you take the heart out here, you call the other one and say, remove the recipient. Now the clock is ticking. If there is an accident in between, the person on the other side dies, right? That's not true of any other organ. Of course, there are medical challenges as well in terms of increasing throughput. How do we make money out of this? We want to avoid trial issues, and also the fact that clinical trials are not fit for purpose for software, which is something that I try to shout as loud as I can, because the circumstances under which software fail might never happen during a trial, in which case the trial is giving you a false warm feeling that your software is okay when it isn't. But different from a plane, you don't take a plane to die, but you can use a medical device that might kill you because of a faulty software. So there's a social technical issue there, regulatorily speaking. You might be happy with a faulty system that saves you. It might kill others. For every 100 patients that it saves, it kills 2, or something like that. We'd like it to kill none, right? The previous work that I have done discovered things where, in a dialyzer that was used on premature babies for 2,000 hours, sick babies in ICU, never had an issue. We found a problem, we played on the machine, and then it manifested itself in front of our eyes. Now what do? You're at the end of a trial. If you change the software, you do restart the trial, or, oh, it's not a software problem. Oh, how come it isn't? Just fix it. So, but on the other hand, what do? You wouldn't have those 2,000 hours of babies saved with none dead. So it's a technical, social technical conundrum of sorts that very much interests me to try and fix it by saying, okay, we are very good at safety critical technologies in the UK. Let's try and gently push them into your world in such a way that you get the point. And instead of doing bare bones embedded boxes stuff, which is what I used to do, try on something that they know is coming, but they don't have a certification framework for digital twins. That's why I'm doing that. And as I said, scuba works at the preservation. You know, you get the organ and you transport it somewhere, but there is a lot of twinning activity that could be done at the processing period. So each one of these is a processing step that takes place until transplantation for a pancreas in particular. There's a lot of twinning capability in here as well. This is what the Leiden people do. Point being, there is more digital twinning opportunities beyond scuba as well. And briefly, just to be on time, you know, it can be used for various optimization procedures, better device evaluation, and so on, and it hopefully will help nibble about the regulatory pathway problems that not only this kind of application, digital twins for medicine, will have, but also embedded boxes, normal, you know, run-of-the-mill control systems have in there. And as a side, Scuba got VC funding recently, and we are going, you know, to the next round of things. So if you have interest or know people who would like to participate in this, come talk to me.